Welcome to Vital Viewpoints on Healthcare, where we explore the biggest challenges and innovations shaping the future of health and human services. Today, we're honored to be joined by Jay Rosen, founder, president, and chairman of Health Management Associates. Jay launched HMA in 1985, and over the past 4 decades, he has remained at the helm, guiding the firm's strategic vision, leading its growth, serving clients, and fostering innovation in publicly funded healthcare. A nationally recognized expert in health policy, health economics, and health finance, Jay brings deep expertise and insight to some of the most complex challenges facing our healthcare system. Prior to founding HMA, Jay led planning and policy development for the Michigan Office of Health and Medical Affairs, where he oversaw wide-ranging health policy research and analysis. With degrees in philosophy from Michigan State University, where he also taught ethics, logic, and the history of philosophy, Jay combines sharp analytical thinking with a deep commitment to public service. He continues to shape the field through his leadership and by serving on the boards of several healthcare organizations. So let's dive in. Jay, thank you for making time to interview with us today.
Thank you for that nice introduction. Happy to talk about all of this.
Excellent. Let's kind of go back to the beginning. I'd just love to hear a little bit more about the early days. What originally drew you to work in Medicaid policy? I guess, how did you leap from philosophy to Medicaid policy and consulting?
Oh, well, that's a long story, but the short version is I had actually intended to become a college instructor of philosophy and was on track to finish a PhD and do all of the relevant things. My timing was not good when the time came for me to find a job doing that. There just wasn't really much going on anywhere in the country. So I thought that I would take what would be a temporary detour into the public service and went to work in the office of the governor of the state of Michigan, which is where the agency you made a reference to was actually located. And then I came across this kind of new thing that had been cooked up called Medicaid in the mid 1970s. And the rest is history.
So I'll sort of maybe then fast forward a little bit to when you stepped away from public service. And take me back to that day at the Big Boy Diner in East Lansing, where the legend is that that's where HMA started, one of those back of the envelope kind of conversations. So what happened there? What was kind of the core idea, and why was it such a pivotal moment in how HMA evolved?
Well, it's a great and at least mildly interesting question. So just to set the stage, when I first began working with this set of issues and questions, Medicaid was a new thing. It's important to remember that Medicaid and Medicare both were dramatic events from a social policymaking point of view in the country. I think not many people know, as an example, what life was like if you were elderly prior to 1965, how you got the health services you might need or how they would be paid for. Different world entirely. Medicare, probably the single most important piece of anti-poverty legislation the country has ever had, lifted millions and millions and millions of seniors out of economic hardship because it introduced a source of financing for health services. And similarly, on the Medicaid side, the system of care for low-income people before 1965 was dramatically different from what we're accustomed to today. So it's important to kind of remember, if we can, what the world was like before these programs came into existence. And I, just as an observer of current events, came to the conclusion that these were monumental accomplishments from a social policy point of view. They rank up there next to creation of Social Security and unemployment insurance and other pieces of what we now think of as being the basic safety net for the country. These were new things. When they came into existence in the mid 1960s, they did not just flip over into full operational mode in 1966. In fact, the last state did not come into the Medicaid program until 1983, when Arizona came in. So it was a very long, slow process for the country to adapt to the creation of Medicaid, in particular in 1965. And its potential was to further strengthen the way the country would respond to the needs of low-income people in particular. Seemed like an extraordinary thing and something I decided I wanted to become involved with. So I spent 10 years between 1975 and 1985 being part of the initial wave of public officials who had responsibility for bringing up the Medicaid program in at least one state. And just as a quick comment and illustration around this idea generally, the early stages of Medicaid, many of the things that we take for granted now were nowhere to be seen. There was no managed care. There was no DISH. There were no provider taxes. There was no behavioral health. In fact, there was only one thing, and that thing was get the money out the door and get it more or less to the right people in more or less the right amount in more or less a reasonable period of time. And it's important to remember that before Medicaid was created, the states had no responsibilities in the health care domain that was anything like what they were being asked to do now. States' experience with health related responsibilities were swimming pool inspections and restaurant inspections and vaccine campaigns and things like that. And now all of a sudden, states were expected to take on the responsibilities of essentially the infrastructure responsibilities of an insurance company, completely alien to anything any state had ever done before. So the taking on of this responsibility to organize and operate a Medicaid program, big shock to the system from just the structure and the scale and the capabilities of organizations like state governments. Really a new thing. And of course, external parties, most famously Ross Perot, came to the states and said, you'll never figure out how to do this. Just let me here as EDS, electronic data systems, just let me let's just have a contract and I'll do this for you. And there were other similarly situated people. And by the way, it's not irrelevant that Ross Perot came out of the military because Medicaid in its early years was seen as a data processing problem, not as a healthcare problem that had to do with get the money out the door. And much of the country's data processing expertise was in the military because in the late 1960s and so on and so forth, the principal issue for the US government was to prevail in the Cold War with the Soviet Union. And the military was where the government's the best and brightest went, who had these systems related and data processing skills. The entire Medicaid program, when I first became involved with it, was the national enrollment was something in the range of 15 million people, maybe 20 million, some number like that. And now, of course, it's 90 or whatever it happens to be at the moment. So it's much smaller, very arcane, very unfamiliar to the states themselves. From a provider point of view, most providers didn't really have a lot of interest in getting involved with Medicaid because it pertained to a small slice of their patient population. When they did get involved with it, it was complicated and it was new and it brought them into a relationship with the state that they weren't all that interested in having. So it's very, very new for everybody. And I had done, this work in the governor's office for however many years. And in the early 1983, 1984, something like that, I and three other individuals, one of whom was at the time the Medicaid director in the state of Michigan, a gentleman named Paul Allen, another colleague of mine, Elliot Wicks, and another individual who worked with me in the governor's office, a gentleman named Jay Ensley, all decided that, well, what the country really needed, now that we had this Medicaid thing out there, was for a group of folks like us to come to them and help them grapple with the challenges that bringing up the Medicaid program was going to create. One other piece of this pertains to the advent of the Reagan administration in 1980. Reagan administration, some of us might remember, it was a while ago, had an ideological point of view, which, among other things, suggested that the federal government should not be involved in the operation of the American healthcare system. And that administration was aggressive and active in trying to limit the federal participation, and it pulled back wherever it could. In some ways, not that differently than some of what we're seeing today. But that didn't make the problems go away. People were still going to get sick, huge numbers of uninsured people. And again, for those who remember this far back, the early 1980s was a period of extreme economic distress in the United States. Healthcare costs were going up at 15, 20% a year. Interest rates were 18% a year at their peak, very high unemployment, lots of distress, particularly in the center of the country, in Michigan, Ohio, Indiana, states like that. So it was a time of great economic turmoil as well in the United States. So our conclusion was, rather than be involved in the efforts of the federal government to reduce the role of public sector in the way the healthcare system operated, we concluded there was no place for these problems to land other than in the laps of the governors. And if the federal government was not prepared to apply its resources to the solution of these problems, the only folks left to deal with them would be leadership at the state level, which we knew intimately because we had been in those roles with the state of Michigan. So we organized health management in 1984, late 84, early 85. And our idea was that we would come to the states and we would tell them that we were there to help them figure out what the answers to these hard problems would be. And that was the idea. The big boy restaurant figures into this because all of the plotting, we were all still active state employees at the time, all of the plotting and the planning occurred in the back booth of the big boy restaurant with the lights turned down low so nobody would see us to see what we might be conspiring about. And the building still stands. There's no historical marker there, but this building is still intact. So, and at the time, there was nothing like us. There was no industry of advisors focused on the public system, and especially with respect to the challenges that we're facing the states around the country. So a very novel idea, but we had confidence that it was a solution to what would be a real challenge for the states. And so we thought we should proceed into this. My colleagues in this early phase were actually quite a bit older than I was. They were actually closer to the end of their working lives, whereas I was maybe more toward the beginning, which accounts for my being the sole survivor at this point. But still, it was a fun and exciting decision to leave the public sector and see if we could figure out how to do this.
So how many states had Medicaid at that point?
Probably by 1985, all of them did. But
Okay.
but
So 85, right? Okay.
but just barely. So
So
Arizona and a bunch of others had come in really just in the late 70s, early 80s. And but it was still new, and it was still a different kind of program than what we have today.
Yeah.
None of these things I had mentioned before existed anywhere. The things that we are familiar with every day and that we work with every day, none of that existed. It was still a fee-for-service environment.
Sure. So what was the core, I'm trying to think about like what was the core value of moving outside the government to then support governors in that way? What were some of the early accomplishments that where you kind of felt like, okay, we got a good business model here? What were the kinds of things you were doing to help governors at that point?
The hallmark of what you might see if you looked back in the history of the program to the mid and later 1980s was the very first emergence of what we now see everywhere we look and call managed care. The idea of using intermediaries, risk-bearing insurance-like intermediaries between the state as a payer and providers and consumers at the other end was a very, very novel idea, very novel. And just coincidentally, Michigan was one of the early sites for the experimentation with the idea of managed care. And so, now it is ubiquitous, and we've got, 2/3 of the Medicaid population is served through managed care arrangements and half in Medicare, but none of that existed at the time. So this was the period in the early evolution of health plans serving Medicaid clients. There were many interesting things about how this happened. There were federal rules, for example, that basically said that if you could not have more than 3/4 of your membership be Medicaid beneficiaries, at least 1/4 had to be commercial. If you wanted to be in the health plan business, you wanted to do business with Medicaid, you couldn't be a Medicaid only plan. You had to have commercial membership as well. There were many, many, many little themes and threads that found its way into this early discussion. It was almost all voluntary enrollment. There was no mandatory managed care enrollment. The enrollment process in those days involved the health plans, the early first wave of health plans, had big groups of salespeople, and they would go from house to house in certain zip codes and try and persuade people to sign up for Medicaid. That's how it was done. Of course, many abuses occurred, and we ended up with elaborate marketing rules. And, now all of that stuff is generally prohibited, and it's mandatory anyways. But anyways, completely different environment. And all of those things, of which I could enumerate 100, which were elements in the evolution of the program and the emergence of managed care as a significant theme in Medicaid. All of that was taking place then, and we were involved in all of that all over the country over the next 15 years, between really when we started the firm in 2000, 2005, which was really the period where managed care took hold in Medicaid. We had a chance to be involved in many, many places. And in every case, it was a matter of figuring out the answer to these kinds of things. How could you get enrollment? What's an appropriate way to market this? What should you be saying and what should you not be saying to lure people to step out of a fee-for-service environment and sign up with some organization they've never heard of before? Really, lots and lots and lots of interesting problems.
So what you're describing is really from the get-go, a lot of innovation, because from the get-go, you were figuring out really how to make this work. And I think that's an interesting subthread. I've always felt like Medicaid is more of a source of innovation than a lot of people give it credit for. But as we kind of, look back and reflect as Medicaid has evolved, what do you think? Which innovations have kind of worked? What particular changes do you think have had the most positive impact on the program?
Again, it's useful to contrast pre-Medicaid with post-Medicaid. Pre-Medicaid, and of course, the original target beneficiaries, if I can use that phrase, in Medicaid were mothers and children and nursing home residents. In those days, there was no home and community-based serve. There was just people in nursing homes and nursing home services. So Medicaid was seen as a adjunct to what we used to refer to as the welfare system, the cash welfare system. So if you became eligible for AFDC, became eligible for Medicaid. You could not become eligible for Medicaid independently. It was seen as an extension of your quote unquote welfare benefits in the late 1970s. Anyways, just to illustrate this, one of the early health plans that operated in Detroit, which at the time was called Comprehensive Health Services of Detroit, CHSD, when they started, their first great undertaking was to convert a burned out, abandoned motel into a clinic for expectant mothers and their newborns. So it was a motel, 2 floors, all the doors are on the outside, kind of a classic, motel. They converted the office into the reception, and then they would tell you to go upstairs to room 201 and see Dr. X. So the conversion of a motel in which all of the exam rooms opened into the outside. Now you're in Detroit in the winter still. You're gonna go upstairs, you're gonna go inside a motel room, which had been converted into an exam room. That was seen as an extraordinary advance in the development of infrastructure to serve this population of low-income mothers and their children. That's where we were in those days. And pre-Medicaid, who knows? Honestly, who knows how the delivery system really functioned for those folks, if at all.
You talked a bit about, the evolution of managed care, and obviously the 80s were an interesting time in the development of managed care and then the backlash that came in the 90s. But I think in Medicaid, managed care remains to be a little bit sometimes controversial today. And I just wonder, in your view, what do you think the biggest contribution is that managed care has made for the Medicaid program and its beneficiaries?
This is a view I guess I've had for a long time, maybe widely shared, maybe not. To me, the deep significance of the emergence of managed care is to create a chain of accountability in Medicaid. So in the old days, where the states are running their own fee-for-service program, you have as an objective anyways, you want your newborns to be getting their child services in their first year or two of life. So, you have to create in a fee-for-service environment, you kind of have to hope that will happen. And you have to, I guess, you can think about creating incentives or nagging the mothers to get their children in and so on and so on and so forth. And if you do it, okay. And if you don't do it, okay. I mean, if you're the agency, who's watching you? Who's measuring your performance? Who's holding you to account for the things that you're supposed to do as the responsible piece of the government to do this? It's kind of a murky thing, what I just described. Now, the contrast is, I have a contract with you. You're a health plan. I have a very, very specific set of things I'm expecting you to do. And I'm going to watch you carefully. And if you don't do them, I have a contractual solution to fall back on. And if you really, really want to do the things you've agreed to do, I'll kick you out of the program and get somebody else to do. So the really deep, valuable contribution of managed care in Medicaid is to be accountable to the administering agency, which is the Medicaid agency, to do a certain specific set of things. So if to serve your population, you need a certain number of participating providers, primary care people, OBs, whatever we happen to be talking about. If you're the state, you have state employees driving around in cars, going to medical practices, asking them if they'd be interested in signing up with this new program the state's running. Or you have a contract with the health plan and you say, it's your obligation to create a contracted network of this size to serve this population. And if you can't or won't do that, we'll get somebody else in here who will. So it completely transforms, first of all, it transforms the role of the government. It's no longer the operator of the machinery of the organization of the system for these beneficiaries. You're now really a contract administrator, and your job is to hold your contractors' feet to the fire. And that, honestly, that's really the story of managed care, is that's an industry that has been built on the idea that it's there to carry out the policy determinations of the government, to run the kind of program the state has determined that it wants to run, and to do it in an environment of substantial accountability. So now you have very substantial reporting requirements, you have HEDIS, you have star ratings, you have quality performance measurement systems, all kinds of things have been developed to watch over the performance of the health plans. So we've given you the money, we've given you the people, and we've given you a very specific set of requirements. These are the things you must do to be in compliance with your contract. And we're going to hold your feet to the fire. So the construct is completely different. Many people have said, and I'm not saying this is entirely untrue, that managed care is all about saving money. It's not all about saving money. I mean, I used to work in the budget office, and if the state had to save money, we had a million ways to save money. That isn't really the issue. But now I've got somebody at the other end of the contract. I can tell them exactly what it is I expect them to do. I can see if they're doing it or not doing it. And if they're not doing it, I'll kick them out and I'll get somebody else in here to do it. And that's exactly what's been happening now for 35 years. And so that the contracting process that the Medicaid agencies have adapted, which is to do these competitive procurements every 4 or 5 years, is really part of what I have just described. It's a way of stopping, saying, let's look at who's doing what we told them to do or contracted with them to do and who's not, and who is able to give me confidence that prospectively they're going to be even better at doing the things that we have determined should be done. And these contracts are awarded, and they're worth billions and billions and billions of dollars. So the competition is intense. It's a competition to be an agent of the Medicaid agency, to carry out the policy determinations that the Medicaid agency has made as to how it wants the program to function. And a number of plans have gotten themselves into trouble in a business sense, and maybe even more, by forgetting that. And so to me, that's really the revolutionary aspect of the emergence of managed care and its adoption by Medicaid is really about creating accountability in the program, knowing what you want to accomplish for the people you're responsible for as a Medicaid administrator, getting competent folks at the other end of the contract to carry out the policy that you have determined should be followed, and then doing the rest of the process to make sure that it gets done. So that's really the essence of it from my point of view.
Yeah. You talked about the growth, obviously, and we've grown beyond just those two populations that you talked about, and um, thinking about even this week as we're recording, right, we're seeing blueprints emerge for proposed changes to eligibility. But the program's grown considerably, and so I guess how do you sort of square that with its original objectives? What makes you most concerned about the program today, whether that's where it is today or the proposed changes, but what makes you most concerned about its kind of sustainability moving forward?
Medicaid is a proxy for the economic profile of the country at a very high level. It's, at least as it exists today, it rests on a pure income-based eligibility determination process. And the eligibility standards are not very high. I mean, 138% of poverty is not a very big number for most people. And nevertheless, we have 90 million people. So indirectly, that's a way of saying, you've got a really, really big swath of the country, 30%. I mean, it's a really big number that are, operating more broadly in an economic environment that's pretty, it's pretty difficult. So I, and I think the country's recognition that as a society, it has an obligation to step in and provide this kind of support for that population, whether it's 138% or 160 or whatever number you want to pick, is a pretty profound positive step forward. We're not going back to having 20 million people. We might go back to having, 85 million people instead of 90 for a while, anyways. But the core concept of the program isn't going to change. You've still got this really, really big subset of folks who live in the United States whose economics are really, really difficult. And financing their own healthcare is completely out of reach for them. It can't be done without this kind of support. They're not going away. Whether the number of people in those circumstances starts to shrink or not is a great question. If it starts to shrink, that would be fantastic for the country. That is, if the subset of lower income folks were to become smaller, that would be great success on another score.
It's an important distinction because I think you raised the point that the core mission of Medicaid is not in dispute, but because we used Medicaid as a vehicle to correct for unaffordability of insurance in the private sector, if you will, or in the commercial sector, now we're having a Medicaid debate. It's not really about the core of Medicaid. It's really about the mechanism by which we are going to help other people who don't aren't categorically poor or disabled or elderly, but who are not able to get insurance and need it. And so, which is a different conversation, perhaps with different solutions. So we've kind of, I guess, backed ourselves into this moment where it seems like we're having a Medicaid discussion that's not necessarily about Medicaid, which is interesting, but both directions, frankly. Let me ask you, if you had a magic wand and you could wield that in a way that would help kind of stabilize and sustain the Medicaid program, what's the one thing that you would change with that, or how would you wield that magic wand?
Well, the Medicaid program is, despite all of the things that it accomplishes, it is very expensive. And it's very expensive, honestly, not because the way it supports the needs of any individual is, you know, indiscriminate from a cost point of view. It's because we're talking about 90 million people.
That's right.
And so, and I mean, everybody knows, I think, that Medicaid runs at, half or two-thirds the cost of the Medicare program and the commercial system. I mean, from a cost point of view, it's an extraordinary success, actually. If you look at it kind of take a risk adjusted point of view and look at Medicaid economics, it's pretty amazing. But the gross cost is it is high because it supports such a huge proportion of the country's population and because it has responsibility in many cases for the most expensive people. The most expensive people are older, frail, disabled people that are explicitly part of the burden of Medicaid to support those folks. Not their acute care needs, that's on the Medicare side, but on the Medicaid side. So long-term care, chronically mentally ill people, developmentally disabled people, very, very vulnerable, very expensive populations. So all of this gets rolled up into Medicaid's cost. The states have very powerful incentives to maximize the federal participation from a financing point of view. It's led to a very convoluted equation in terms of how the financing works. It's much more complex than you would expect it to be if we all could agree on who belongs in the program and who doesn't, and what its real costs are, and what is a sensible financing equation as between the states and the federal government. We waste a tremendous amount of time. When I say we, I mean all of us involved in the way the program operates, whether you're within, you're in the public service or you're in the kind of position that we occupy. Tremendous amount of effort goes into pushing responsibility back and forth between the states and the federal government as to who's going to pay. I think that a rationalization of the financing system would be an extraordinary improvement in Medicaid. If we had stability in the financing structure for Medicaid, a lot more effort could be devoted to making the program run well, and a lot less effort would need to be developed or devoted to trying to get somebody else to pay, which is what we spend a huge amount of time on. But, it's important to remember it's just a really, really big program. It comes in 50 different flavors because that's just what it is. And so the complexity of the thing is extraordinary. And from my point of view, it operates very, very well, given the nature of the problems that it is charged with addressing. But getting to a more rational and stable financing equation would be a great step forward for the country. And really, that in turn rests on getting to the kind of consensus we were talking about a few minutes ago about what the role of Medicaid is and is not, and embracing that and building the program on that solid political foundation.
Are you optimistic right now that there could be a rationalization in this current environment?
I don't think in 2025 we're going to see much rationalization. I actually think this debate, which is going on now, is having the effect of bringing into clear focus the degree of support in the country that the Medicaid program has. The Medicare program, nobody's talking about anything.
Right.
So, Medicare is settled. In Medicare, what are we talking about? dental benefits maybe, or an continued expansion and growth of the Medicare benefit. In Medicaid, I mean, everything we see, every time anybody goes out and asks folks, where do they stand on Medicaid? There's just extraordinary support for the program. And now they're asking about it right now because it's threatened. Normally pollsters and other public opinion people don't go around asking folks about that, but they're asking now. And what they're finding out is the support is very broad and very deep, not particularly partisan. I mean, you get virtually the same results in red states that you get in blue. So I think that the actual kind of unexpected benefit of this debate we're going through is that it's bringing more clarity to where the people of the country stand on something like Medicaid. And where they stand is they want it, and they want it to be there, and they want it to be available for the folks who need to have it.
Yeah.
So I don't think anything's going to get resolved in 2025 because there's too many other, dynamics operating here. But I do think in the long run, it's a way of communicating to the political decision-making process that this is just something that's got to be part of the deal for Americans, and the government is expected to maintain it in reasonably good shape.
Yeah.
I don't have any opinion about how this is all going to express itself, but I actually think that the main result of this thing we're going through now is going to be to strengthen support for the program in the long run.
That's fantastic. It's probably a good note to end on, a core truth.
Yeah.
Well, thank you so much. I certainly learned a lot about the firm and about the Medicaid journey, and I really appreciate your time and sharing those insights with us today, and look forward to another 40 years, right?
Very good.
This episode of Vital Viewpoints on Healthcare is sponsored by HMA Information Services. HMAIS is a subscription-based service that provides state-level data on publicly sponsored programs like Medicaid. From the latest managed care enrollment, market share, and financial performance data to up-to-date RFP calendars and state-by-state overviews, HMAIS has all the information you'll need to power your initiatives to success. This podcast was produced by myself, Jennifer Colomonico, along with Tiffany McKenzie, in collaboration with our guests. The content is the property of Health Management Associates.